My name is Edward Kashmer, a psychiatric mental health nurse practitioner student at the University of Texas Rio Grande Valley. Today, I am presenting a case study on Mr. Wesley Brown, a 63-year-old businessman who is married and has one sibling, a sister, and no reported children. Mr. Brown was found down in the road by police and transported to the ER. Psychiatry was consulted for management of psychotic behavior. Collateral information that was obtained by his family, including his wife and sister, reported that he had been running around the kitchen with knives, sending paranoid emails about justice system to his friends, showing his guns to the neighbors, seeing people in the walls, paranoid thoughts that his wife was having an affair, not sleeping, reported missing by his wife. His car was found a few blocks away, in which the trunk contained numerous medications along with his extensive gun collection. And he reported that he took daily doses of opiates for his chronic back pain. The onset and duration was over the last 2 weeks. He has a past medical history of coronary artery disease and chronic back pain. Past surgical history includes coronary artery bypass 5 years ago, with several lumbar fusions without complications. No reported allergies at this time. Current medications include metoprolol, cyclobenzaprine, and morphine. No psychiatric history was reported. Subjective data collected enlists the characteristics previously mentioned in the HPI. Objective data showed his vital signs were stable, although he presented unkempt and disheveled, and had slurred speech and appeared heavily sedated with altered mental status. Other characteristics included urinary retention, mydriasis, hypoactive bowel sounds, and decreased reflexes, all likely as a result from having taken tricyclics and benzodiazepines. Mr. Brown had a psychiatric evaluation completed and was screened using the Mini Mental Status Exam, or the MMSE. The Mini Mental Status Exam is a 30-point questionnaire used to measure cognitive functions, including attention, executive functioning, language, memory, orientation, thought content, thought processes, and visual spatial proficiency, and has a sensitivity of 0.87 and a specificity of 0.82, and has been validated as the best assessment tool to diagnose delirium or dementia. Mr. Brown was shown to have severe cognitive impairment with a MMSE score of 16 out of 30. The Confusion Assessment Method, also known as CAM, and Confusion Assessment Method ICU, are other assessment tools that takes less than 1 minute to complete. The CAM has a sensitivity of 86% and a specificity of 98%, and have been shown to reduce missed delirium incidents when used by clinicians. Appropriate screening for substance-induced delirium and early detection of hypoactive, hyperactive, and missed delirium can minimize worsening symptoms of delirium and reduce mortality. Again, the CAM assessment tool is shown identifying specific criteria that supports the diagnosis of delirium. The diagnosis of delirium requires criteria 1 and 2 to be present, and either criteria 3 or 4. All diagnostic and lab findings were unremarkable except for the toxicology report, which was positive for benzodiazepines and tricyclics. It's important to point out that Mr. Brown had no history of having these prescribed, and interesting that the toxicology report was negative for opiates since the family reported he had been prescribed morphine for his chronic pain and was taking them daily. Differential diagnosis based on Mr. Brown's health history, subjective and objective data, and the diagnostic and lab findings include paranoid schizophrenia, delusional disorder, acute psychosis, mania, substance medication-induced psychotic disorder, vascular dementia, and substance intoxication, which were all with perception disturbances. Of all of these, the substance medication-induced psychotic disorder is strongly supported by the clinical presentation and therefore can be included as one of the primary diagnoses. Based on the pertinent information on this case study, the primary diagnosis for Mr. Brown is severe tricyclic and benzodiazepine substance-induced delirium acute mixed, or severe tricyclic and benzodiazepine substance-induced psychotic disorder. Delirium, as defined by the DSM-5 criteria, is an acute fluctuating syndrome of altered attention, awareness, and cognition with onset from days to weeks. There are three subtypes associated with delirium: hypoactive, hyperactive, and mixed. Hypoactive characteristics are often mistaken for depression and can lead to a delay in a diagnosis and treatment. If delirium is not treated, the prognosis is poor, resulting in psychological stress, functional and long-term cognitive impairment, prolonged hospitalization, increased healthcare costs, and ultimately death. With early detection and intervention, full recovery is possible. A complication that arises from the use of taken tricyclics, or TCAs, is anticholinergic delirium, and caution should be used when prescribing these agents. Amitriptyline is one type of tricyclic antidepressant that has a half-life of 10 to 26 hours. Therapeutic levels should be monitored routinely and the medication titrated or tapered accordingly to avoid tricyclic toxicity, which presents in 5% of the population taking TCAs. In our case study, Mr. Brown's toxicology report was positive for tricyclics, although there was no history of him ever being prescribed or treated. Tricyclics function by blocking muscarinic receptors that result in anticholinergic symptoms, which were observed with Mr. Brown. Those symptoms included urinary retention, mydriasis, dry mouth, drowsiness, confusion, illusions, hallucinations, with visual being more common in delirium than audio. Beers criteria, also commonly referred to as the Beers list, is a guideline developed by American Geriatric Society that is used as a safety measure to help healthcare providers identify inappropriate medications that should be avoided or dosage reduced, especially in the older population. Several drug classifications listed on the Beers list include tricyclic antidepressants, anticholinergics, antipsychotics, barbiturates, and antihistamines, to name a few. Other considerations are the use of opiates, which can also increase the risk of delirium, especially in the elderly. The primary goal for treatment of delirium is to identify the underlying cause, then initiate non-pharmacological measures providing supportive care. If delirium is a direct result from a substance or medication, then the primary treatment is to discontinue or titrate down on the medication. In conclusion, early detection of predisposing and precipitating factors can help identify those at risk for developing delirium, and appropriate intervention can be implemented that could reduce this life-threatening disorder. Thank you, and this concludes the case study presentation.